Hello, and welcome to the panel discussion for the IBS section of the Nancy and Bill Norton Patient Education Series 30th anniversary event. You just heard three wonderful presentations, one from Dr. Lin Chang, professor of medicine at UCLA in California. And then also we heard wonderful stories from Miss Deborah Caton, who is told us about her life journey with IBS-C. And then also Lisa Strykowski, who shared her illness experience with IBS-D. So just to jump right in, we just had these great patient illness experience stories shared with us. Dr. Chang, you have a practice at UCLA. You've been in medicine for a very long time. Would you consider these two stories typical for the IBS population?
Well, I just to preface that I want to say that I work at a tertiary care referral center, and my clinic is comprised of patients with more severe symptoms. I think Lisa's story was similar to what I've seen and heard. I think Deb's story is a little bit more out of the ordinary, just of everything she went through. And normally patients with IBS with constipation don't really have to go to the extent of getting tube feedings, but it just illustrated the challenge that she experienced with very severe symptoms, getting the right healthcare team and the right management approach. But I would say that was more extreme than what I've used to seeing. But IBS, even though we have certain symptom criteria, abdominal pain associated with diarrhea and constipation, the group of IBS patients is still heterogeneous. They're not all the same. They're not going to have all the factors that really contribute to symptoms or respond to the same treatments.
Absolutely. I know at one point I told someone, if you give me 100 IBS patients, there's probably 100 different treatment options for each of those patients because they can be very different. So for those of you at home, please understand that we have these wonderful illness experience stories that we heard, and those are real life stories of patients with irritable bowel syndrome. But if yours looks a little bit different, that's okay. And it's still relevant and it's still important to you, and you should be seeking care with your physician. So before we proceed into talking a little bit more about personal, the stories that we heard, I want to back up a little bit. I want to talk about the doctor-patient communication, because we're talking about the different patients and how they can have different symptoms and that sort of thing. But let's say someone thinks they have IBS. Dr. Chang, what are some things that you want to hear from them in clinic? What are some things, because we know, like you said, it's heterogeneous, but what are the important things that they should be conveying to you so that you can help get the right diagnosis and the right treatment plan?
I mean, there's different aspects I think that are important. The most important is being able to convey the symptoms that the patient has experienced, because these are symptom-based diagnoses. So the history, the medical history is everything. And so if the patient can convey what symptoms are experienced, what makes it worse, what makes it better, and their whole experience and what tests they had or what have they been through, what are their expectations, also what's the most bothersome to them. You really want to focus on what's most bothersome, what's impacting their quality of life the most, and really what they want to get out of it. I do think it's helpful for a patient. The problem with the internet is that there's too much information, and sometimes you can go down these different paths. But it is important for the patient to be more familiar with some of the possible diagnoses, some of the tests that are done. A lot of doctors talk with a certain medical lingo, and they don't always translate it. So what they can understand is probably very helpful. So it's preparation.
Preparation. That's fantastic. Preparing for your doctor visit is always really, really important. So, Deborah and Lisa, what about the flip side of that? So you've both had a very long history with your IBS, and you've been to see lots of different doctors, and you've had a lot that you've had to convey to doctors and hear from doctors. What are some things that you would say were the most helpful for you on your journey? Deborah, you want to start?
Gosh, I went to so many different GI doctors. And even when things got really bad in the fall and winter of 2019 into 2020, I felt like I finally started to get the most help even though it was all done via phone because of COVID, when the doctor that I finally found was willing to explore more options with me, to start to say, oh, it's not just this, that he was able to look outside of what I had already been doing and start to recommend lots of other options, things I had never heard about before, even though I didn't necessarily describe any different symptoms to him than I had anybody else. Some of that was, like Dr. Chang said, from the research that I did, but some of it was just his knowledge base and his willingness to think outside of the box with me. I mean, that was a turning point.
Fantastic. What about you, Lisa?
I think that the helpful thing was knowing it was just IBS, but then the most difficult thing was knowing that it was IBS. So knowing that it wasn't a major diagnosis was a relief, because it's like, okay, I'm not as sick as I think I am. But the aftercare is kind of not, it wasn't there 10 years ago when I was diagnosed. It was just, well, that's all it is. You know, you can take over-the-counter medication. It's fine. And I think that was difficult, was being able to navigate that on my own, because I didn't know who to go to after that. I had already gone to my primary care and I'd gone to my gastroenterologist, and I thought, well, okay, that's it. There's nowhere else to go after this. So when I started researching this on my own, I realized, oh, nutritionist would have been helpful to be recommended to, and stress management. So maybe some psychological care would have helped too. So again, I think knowing that it wasn't a major illness was great, but again, not knowing what to do with it after was difficult.
Absolutely. And so both of you ladies said in your story, you talked about in the early days, self-medicating, trying things over the counter, you know, trial and error, and really not sort of really going to your gastroenterologist and really trying to get that help. And Lisa, you just alluded to maybe your doctors were kind of, well, you know, there's nothing we can do for you way back when, which I totally understand, because my first IBS diagnosis, I was in my early 20s. And the doctor said that to me as well. Congratulations, there's nothing wrong. It's IBS, you know, go in peace. And so it was, you know, it was difficult, right? So you had to self-manage. And then you made a decision to start seeing the doctor again. And Deb, you as well. You spent quite a bit of time self-medicating, trying to figure out what worked for you and what worked for your body. What was your reasoning for self-medicating for as long as you did?
Mine, I think I've learned that a lot of it ended up being very much connected to my mental and emotional health. I also have, which I didn't even know there was a term for this, I have emetophobia, which is a fear of vomiting, which doesn't fit really well if you're constipated, because then you're afraid of being too full and vomiting. And so I was self-medicating in any number of ways to not to get over that fear. And once I finally figured out that a lot of this needed more than just, you know, Pepto-Bismol or Gas-X or something, that, I mean, I had never heard of a GI psychologist. It never occurred to me to see a dietitian. So I was doing that to, I don't know, keep my mental and emotional self calm. And yeah, in the end, and then trying a super restrictive diet on my own without help was probably one of the worst decisions that I made that led me down that path. So, and that's one of those, like Dr. Chang said, there's so much information out there, but you have to use caution with it.
Mhm.
So, Dr. Chang, what about what you see? Is this normal that people would self-medicate and try to take care of their IBS for a while? And if so, at what point should they think, you know what, let me go see a doctor? How can I maybe get some help?
You know, when I was listening to what Deb and Lisa were saying, you know, I'm older than all of you. I've been doing this a long time, and I would say that when I started over 25 years ago, people didn't even know really what irritable bowel syndrome was. What happened was there was a company that made a medication, the first medication approved for IBS many, many years, called Elocitron. And that's where industry actually started putting in some investment in educating the public and healthcare providers So a lot of people now, I think most people will know that term IBS. They may not completely understand what it means, but most people are familiar. But back then, people were not familiar. There weren't that many options. You had to self-medicate. People didn't have as much knowledge as they have today. I mean, I was just thinking how, we're talking about low FODMAP or medications that we didn't have that, not that long ago. So what we know now, we can't really think about too far back because that knowledge wasn't there then. And so a lot of patients did have to utilize it. And, even to this day, I think it's at least half of patient or individuals with IBS symptoms don't seek healthcare, probably for different reasons, whether it's the lower severity, not sure a healthcare provider can help them. You don't know if it's going to really make a difference. Maybe they're not comfortable. So there's a lot of different issues. But I do think it's important for patients to tell their doctor if the symptoms are really bothering them and it's impacting their life or they're concerned of what they have. It's okay to share that information because we get scared of what we don't know, and if we're anticipating all these other potential thoughts, it could amplify everything. And knowledge is power. And you just want to make sure you're going to the right people who have that knowledge, who are giving you accurate information, who you trust.
Absolutely. That's probably the one of the most important things. Like you said, Dr. Google has a wealth of information, but make sure that you're using great websites with some good education that's scientifically valid and not, just people that are trying to sell you something. If you're on a website and there's ads and they're trying to sell you something, that's probably not a good place to get scientific information. So that's so true. So I want to talk a little bit about all of the different medications. So you ladies tried a lot of stuff. So we heard some stuff about acupuncture, herbal remedies, a lot of loperamide, and Lisa, you said that you became allergic to it. And can you explain that a little bit more? Because I think a lot of people,
Yeah.
especially those that self-medicate at home, use the loperamide. And tell us a little bit about that.
Yeah, so I would take, they said, the healthcare providers at the time said, you just might have nerves that go to your gut. Taking the over-the-counter stuff when you need it is fine. And so I would take it as needed. And eventually it turned into 4 to 6 milligrams a day. I would just pop 3 pills in the morning just to get through the day. And I think Deb nailed it, that you self-medicate out of fear. And I'd be so afraid that I would, the urgency would kick in while I was driving or while I was in a meeting. So it was so much easier to constipate myself than it was to, struggle with finding a bathroom at the worst time. So eventually I would take the loperamide and I would start getting IBS-C symptoms. And I would be cramped and doubled over for 2 hours. I would have a hard time passing stool, but at the same time, to go through that every 2 or 3 days was much better than worrying 2 or 3 times a day if I had to go. And eventually I started to get hives. Like I said, the stomach aches were daily. I would cut back, cut back, cut back. So what was 6 milligrams a day, I would take 1. I would take half a pill and I still couldn't even tolerate that anymore because I had taken so much for so long. I think my body had just had enough.
Also,
So
what does happen over time is some patients will switch bowel habit predominance. It's more characteristic where you have the mixed bowel habit type, where you have abdominal pain, alternating constipation, diarrhea. This is without any medication, though. This is spontaneously. You can shift into IBS with constipation or shift into IBS diarrhea. But in one study, they did show that 15%, which is a smaller percentage, but they can shift from IBS with diarrhea to constipation and also the other way around. But even if you didn't, Lisa, it is not so uncommon that when you take a little bit of loperamide, you can completely go the other way, and that really limits the use of it.
and Dr. Chang, I know in your presentation you talked about therapies, and there are other therapies that people can use besides the loperamide. I know that's the one that most people know about, the Imodium. It's available in generic. You can get it, just about in any store. But there are other options for people with IBSD now. I know for a while there wasn't.
Yeah, and it can range from diet, like low FODMAP, to over-the-counter remedies, like Lisa took, and also there's prescription agents. Rifaximin, which is a non-absorbable broad-spectrum antibiotic, although it's a short course, can help improve IBS diarrhea symptoms, and also oxazolone, which is similar in mechanism of action to loperamide, but it's different. It's a mixed opioid blocker, and then also what we call agonist, where it acts on the opioid receptors, and that can help as well. And then elocitron that I mentioned previously, but that has some restriction. And then you can use off-label antispasmodics for IBS with diarrhea that helps after meal symptoms, and also neuromodulators, which I think both of you have been on. For the constipation, the class that is people use outside of over-the-counter laxatives are the secretagogues. We call them secretagogues, meaning they bring chloride and sodium and water into the bowel wall, lumen of the bowel, and then moves the stool through, and that's linaclotide, plecanatide, and lubiprostone. And then tegaserod, which is, I don't know if everyone remembers that medication some years ago. So it works on the serotonin type 4 receptors, and it is what we call a promotility agent, where it causes contractions and movement. There was a commercial that won awards back in the day, where people would lift up their shirt and say, I don't have any more bloating. I don't know if anybody remembers that commercial, but that was for tegaserod, and then it got withdrawn, and then because of concerns of heart problems, and then they brought it back to a limited indication for women with IBS with constipation under the age of 65 without cardiovascular disease. So we have a lot more options than we used to. And then there's, of course, behavioral therapy. You don't have to take a medication. That has been like cognitive behavioral therapy and gut-directed hypnotherapy.
And you mentioned the FODMAP diet right off the bat, Lynn. And I think that many people with IBS have tried or on the low FODMAP diet. And of course, we always encourage people to seek the advice of a dietitian or nutritionist. Like Deb, you were saying that was one of the worst things that you could have done, was trying to do that yourself. The reintroduction phase of that can be very treacherous to navigate. And it is so important that you do that reintroduction phase. But one of the things that, I'm just curious, Lynn, when people start taking things out of their diet because of the low FODMAP, and maybe they can't have beans or legumes or things like that on plant-based proteins, then you're looking at what's left of what they can have. And then if you have other things like diabetes or cardiovascular disease or things like that, how do you balance the elimination and in the rest of your life, right? So you trading your IBS symptoms for something else.
Well, you used a really good word, which is balance. And there's a lot of balance that has to be achieved in many different ways. And diet's just one of those areas. But diet is, the majority of IBS patients, their symptoms get worse after they eat. And it's one area that a patient can control their symptoms. There's something they can do to be actively involved. And it is correct to eliminate certain trigger foods. I think where the problem is that IBS is so unpredictable that one day a certain food can bother you and have worse symptoms, but if you eat it on another day, it doesn't bother you. But you're thinking, am I intolerant to this? I better take it out. So then what happens is more and more you remove foods. And then if your gut and the gut microbiome hasn't seen a certain food a while, and then you try to eat it, then you get symptoms and you think, okay, I must not be able to tolerate that. So then you keep going down this path. I mean, there's a reason why we have GI dietitians, because we really need them. But I always give the explanation for myself. For example, I don't have IBS, but I'm lactose intolerant. It doesn't matter what day of the year or week it is. If I have a cup of milk, I'm going to have GI symptoms. But that's a true intolerance. But there could be days that one day you're eating spaghetti or pizza and you do terribly because your symptoms are in a flare at that moment. And other times it doesn't bother you. And you're probably not really intolerant. It's just probably the gut doesn't function as well. It's more sensitive. The motility and secretion is abnormal. So I think keeping a diary and making sure you're only eliminating foods that are consistently triggering your symptoms is really important.
Very good. Yes, and I think that, daily diaries can be very helpful to some people, and some physicians really like that when someone comes in with a daily diary. Deb, Lisa, have either of you tried doing either stool diaries, food diaries? Has that helped? Do you have any suggestions on that? Deborah, I see you shaking your
I
head.
know
So
I did. I did months and months worth before I found the GI doctor and the whole team that helped me. And then I continued to as I was working through the tube feeds and eating and all that. And yes, it was extremely helpful, especially since I had to monitor weight and you forget, right? From one day to I think I ate this. I don't know how much. And even after I got off the tube feeds, I kept it up. When I was trying to reintroduce things. And I will say though that eventually, once I reached weight and I was doing okay, but still not eating enough, my dietitian actually recommended that I stop, because there comes a point where the disordered eating and the obsession over food, it's detrimental. So I don't do it anymore. I just, kind of keep track and eat when I'm hungry. And so it's beneficial for a while, but I don't know, always for somebody with disordered eating, it's a bad idea after a while.
okay, definitely true. Lisa, how about you?
Yeah, I actually did. So opposite of Deb, I had tremendous, success with FODMAP. I actually found a lot of trigger foods. And when I'm feeling good, I won't track it. But a few months ago, I actually had a flare up again. I started tracking everything and I found out it was actually stress related this time, which was great. So I'm now being treated for anxiety disorder through talk therapy and medication. That's actually helped a lot of my symptoms. But even looking at, the food diary, it goes beyond the food diary. It's, what time did I wake up? What events did I go through today? How was this meeting? How was that? So it really is documenting like your full day besides food to see if maybe it's, an environmental trigger, stress trigger, anything like that. So for me, it's been very helpful. But again, I only do it when I'm having flare ups. I don't do it consistently every day.
I
Is
think
that
Lisa
something that
brings
you
up
recommend?
I think Lisa brought up a really great point to hit home on is when you do these daily diaries, you should really think about any potential triggers or contributing factors that not a lot of people are not aware of or maybe even not open to. And you obviously both are open to different, more of the holistic and understanding there's multiple environmental and diet and many other factors, sleep. But I also agree with both of you that 2 to 3 weeks is probably a good set period of time. But the other time that I tell patients to do diaries is if we're going to make an intervention and you want to determine what effect it's had. So sometimes those time periods are helpful.
Fantastic. And what about preparing for a doctor visit? So if somebody was coming to see a doctor for the first time, is this part of the preparation that you were talking about? Would that be helpful to you as a physician to see that a couple weeks, or would that be something to do maybe after they talk to you and then track and see how things go?
I think it's fine to have a symptom diary. Again, it's the patient being able to convey their story,
Mhm.
convey what their experience. That's the part, and it's important part. So if they can do that by showing a symptom diary, then they definitely should. But you're usually going to be looking for symptoms for a much greater period of time than a few weeks. But if that's helpful, but the other point I want to make about symptom diaries, which I think you both have done, Lisa and Deb, is when you do the diary, you're looking at it and you're determining what you're picking up from it. What did you learn from it? Rather than the patient just handing it to the healthcare provider and saying, you look at it and tell me what you see, which we both should. It's a partnership. But I think patients can learn a lot about their symptoms and the triggers and the alleviating factors if they study their symptom diary themselves.
Yeah.
Absolutely. And Lynn, you made a good point about being able to convey their story. And so one of the things that I've heard that is very helpful for people is to practice their story. So before you go to see your physician the first time, maybe tell your spouse or a loved one your story and see how well you can describe that. And has anyone ever tried that? Lisa or Deb, have you ever, sort of gone over what you want to talk to your doctor about with someone else and sort of bounce those types of things?
Not with someone else, but inside my head, yes, I pre-plan my conversation. I remember the highlights, I write them down, and I bring them with me.
Yeah, same here.
Fantastic.
I actually think it's helpful when patients bring, a family member or because, especially someone if they're living with them, because sometimes they'll add another perspective that's helpful. And then the information the healthcare providers conveying to them, they may pick up other aspects. Because I always say this, and I said it, many times, is the healthcare provider only gets a snapshot time with the patient, but the patient is experiencing a lot outside in their home and work and elsewhere, and it's good to really get a good view and a perspective of what they're experiencing, and people that are care about them and providing some information and support. It's good to have them there as well for different reasons.
Fantastic. So I want to dig a little bit I just want to make a comment about Deborah's story. So Deborah, you started out in your video, you said you were sort of born with constipation. So you were constipated even at a young age. And then when you got older, began to have the IBS symptoms. So the pain and discomfort associated with your bowel movements didn't happen when you were younger. That's correct?
Yep. Yeah, when I was young, yeah, I remember it always being bad, but it wasn't until my early adulthood, college years, where I started to really pay a little more attention. And it wasn't until I was in my 30s late 30s, that I ever got, quote, a diagnosis, I guess. It was just something that I lived with, dealt with.
Yeah,
So.
absolutely. So Lynn, is this normal? I mean, I know that for me, I was constipated for a long time, and I can't even remember if there was pain associated when I was a child. But is it normal for someone to sort of have that low grade, the constant constipation, and then as they get older, then they start having the discomfort and the pain and the other things that come with IBS? Or do you think it was IBS all along?
It's interesting when patients present with chronic constipation, they very often will say, "I've had this all my life." And then I always want to know what age are we talking about? You don't hear so much, "I've had diarrhea all my life." You hear the constipation. Constipation is very chronic. I've seen patients, Salon, I've noticed, although I don't think I've ever read this, but with Deb's story, where they'll have constipation without abdominal pain when they're younger, but they'll develop abdominal pain later, whether it's college or teens or older. But I've seen that pattern, and I'm always thinking about that. Is it because there's obviously a predisposition for constipation? A lot of times there's a family history, but that there's slowing, that's more of a motility problem. But then as it progresses, it becomes now more of a sensory or pain, discomfort, bloating disturbance, along with a motility disturbance. And so it's probably some progression, but I've actually seen that a fair amount.
And you said that generally doesn't happen with diarrhea. And any idea why that doesn't happen with diarrhea?
Well, diarrhea a lot of times is intermittent, and people may have it after a certain meal or under stressful situations. I've seen that, or a sensitive stomach, and then those develop it more. I just feel like that can be a little more fluctuating than constipation. Constipation seems to be more steady and progressive.
Right. So I want to be cognizant of time here, and I just thought we'd wrap up our session today with advice for the people that are watching us today. What are some things that maybe we want to leave with them, of things that advice for living with IBS? And Deb, do you want to start for us?
Gosh, I guess the two main things that come to mind are, one, if you're not getting answers, keep looking. Don't just give up. If you have any opportunity at all to keep finding somebody to help you, not Dr. Google, but others. And as Lisa mentioned earlier, I think prior to our conversation here, the idea of the brain gut connection I had no idea until all of this that our gut is full of neurotransmitters, and how much, you know, our mental, emotional health, as well as any medications, neuromodulators, have an impact on that. And so don't leave that stone unturned if it's something that you can address.
Fantastic. And what about you, Lisa?
I think Deb hit on emotions, which I think is huge, especially when you go in for your initial diagnosis or if anything's changed. Be specific. And I think that, you know, sometimes medical professionals want to quantify how many times a day you're getting sick, what's acceptable, what's this. But you can't quantify emotions, you can't quantify feelings. If you tell them that you have fear from your, you know, if you're going to get sick in public, if you have, you know, if you're feeling isolation because you can't leave your house, if you're depressed, if you're anxious, you know, make sure that your emotions are part of your physical, what you bring to the doctor with you, because that's going to play a huge part in, you know, the whole body kind of diagnosis. And, you know, so again, just be as specific as you can with everything that you're currently going through.
Fantastic. Great advice. And Dr. Chang, how about some last words on what you would leave with the community?
I would say that these are very common conditions that our understanding has evolved over time, both as understanding the physiology. So even though our standard Western medicine tests can't find a structural issue, these are true, real symptoms that are just due to physiologic changes along the brain-gut axis, and that treatments have evolved, as we've said. But I think both of you are saying the same thing, you know, look at the whole person, and we have to all be honest and open to ourselves and to each other, and sharing it. That's how you get to you know, finding what really works for patients. But I think there's definitely hope. There's validation, really trying to reduce the stigma of having IBS.
Fantastic. And, you know, as we've all keep saying, you know, we all have this journey, and there are so many people out there. Lynn, maybe you can tell us what is the current estimate of people with IBS? I believe you said it in your presentation, but can you
Yeah,
remind us all?
it depends on what symptom criteria you're using, but it's between 4 to 11%, and that's in the United States, but and worldwide, but it varies in different countries. But it has a worldwide prevalence. It's very common.
Absolutely. Very, very common disorders. And to make sure that you know that you are not alone, and there are those who are there to help, and there are teams, as Lisa and Deborah have talked about, with dietitians and behavioral therapists and wonderful gastroenterologists. If you need help in building this team and finding doctors close to you that do specialize in irritable bowel syndrome, reach out to IFFGD, and we'd be glad to try to help you find a physician in your area. So Deb, Lisa, Lynn, thank you so much for being here, for sharing with us. Lisa and Deborah, especially sharing your story. Sometimes that can be very difficult, and you're really sort of putting yourself out there and letting us know what that illness journey has looked like for you. And so we really appreciate you doing that for us, and for all that you do in advocating for patients with IBS and other GI disorders. And then, of course, Dr. Chang, longtime friend of IFFGD and one of the program chairs for this meeting. So thank you so much for your dedication to patients and for taking this extra step, this extra time to do this special video just to wrap up this panel session. And for those of you watching, thank you so much for being with us today, and we hope that you enjoyed this and all the programming of the Nancy and Bill Norton Patient Educational Series.
Thanks.
Thank you.
Thank you.